Good morning, everyone, and welcome to our webinar today, which is entitled New Year, New Way, Viable Solutions for LTC Staffing Shortages. My name is Ken Bell. I'm the Marketing Executive for Simple LTC and NetSmart. I want to thank you for joining us today. We are very excited to partner once again with QRM, Quality Rehab Management, to offer this free educational opportunity for you. And Simple LTC is your host for today's webinar. Simple LTC provides MDS and PDJ analytics and workflow software to over 5,000 facilities around the country. As you may know, we're now part of the NetSmart family of solutions, and you'll be hearing more about NetSmart as we continue to develop more tools for the post-acute industry. So before we get started today, just a couple of very quick housekeeping notes. We will post the handouts here shortly, and we'll put them in the chat, so you can download those as a PDF here shortly. And for Q&A, you can feel free to ask questions at any time during the webinar. Just click on the Q&A button and type your question in there. Amy Gerlach with QRM is also with us today. She'll be monitoring those questions. And then Susan will address as many of those as possible during our Q&A section at the end. One quick note, please be sure to use the Q&A button to post your question, not the chat button. If it's in the chat, we might miss it. So be sure to put that in the Q&A section. Now I'd like to introduce our speaker. Susan Krall is the Chief Strategy Officer with QRM. She's a physical therapist with over 30 years of multi-state post-acute rehab management experience. Her client base includes for-profit and nonprofit SNFs and CCRC campuses all across the US. And Susan's primary focus at QRM is partnering with her clients to identify and implement strategies that drive enhanced outcomes and patient satisfaction in our ever-changing PDPM world. So thanks so much for being with us today, Susan. We really appreciate you sharing your expertise, and I'll go ahead and turn it over to you to get us started.
Oh, thank you, Ken. I appreciate the opportunity again to be with you all. And we're talking about staffing shortages, so everybody's time is precious. So I really do value the fact that you are joining us today. And I hope that I can leave you with some options to help that staffing shortage, right? So that's what we're here to talk about. You know, before COVID happened, all we heard about was this staffing crisis that we were going to be facing as the silver tsunami took hold and really hit us hard. And then with COVID, now what are we in, our third wave of heavy tsunami impact to our industry with COVID? So it's like, I cannot imagine what your days are like and how you've been managing through it. You've lived it. Clearly the headlines are covering the crisis and the staffing shortage. So I just pulled a couple of three from the other day that were, I think, shared in Provider Magazine and some other places, and we've cited the articles and the references. But, some of the statistics that they're citing are that, we're bracing this Omicron situation with 15% fewer workers today than we had when the pandemic began. And we already were in a shortage, right? And then we've lost over 425,000 employees in the past 2 years. So this is really causing quite the pain. I mean, it's unbelievable, right? And so sadly, about 58% of the nation's 14,000 nursing homes are having to limit admissions. So it's really forcing everyone to be creative, to think outside the box, to look at where are our options here to take care of our patients. So our objective today is really to look at some viable solutions that we believe have been helpful in the buildings that we are in and that we have worked closely with by allocating the rehab department specialists to plug some of those vacant holes and to help fill in when necessary. So it's not everybody's first thought to go to therapy and fill in. So we just wanted to share what we've seen, how we can help from the therapy perspective fill those gaps, why we think it's important to use everyone's skills today to their fullest level to help fill some of the staffing shortages. So we'll go dig in here a little bit. And we can go to the next slide. Thank you. Why rehab? So that's what you might be asking, right? So as you probably know, if you know very much about therapy, we are all in everybody's business when it comes to functional recovery and rehab and safe transitions. That's what we're here for. Quality of life, we are held accountable to maintaining the highest, obtaining and maintaining the highest possible level of function. Not just in today's value-based world, but this goes way back, right, to the beginning of when therapy was mandated through OBRA. And, now we're looking at bundles and ISNPs and, all kinds of penalties and benefits and rewards for quality of care. It's all publicly reported in Care Compare now, and we're being held accountable publicly to obtaining and retaining improved and higher functional levels, improved ADL performance scores, decreasing our return to acute at all times if avoidable, and successfully returning our patients to the community when possible. So that's what we're being publicly held accountable to, as well as, from our own professions. That's what we're here for. And PT, OT, and speech areas, we are really guided in our education and our training to do just that. Our programs should be designed for all of our clinical education programs, is what I'm talking about here, for PT, OT, and speech, are designed for professionals providing us with education founded in anatomy, neurology, musculoskeletal systems, with the end result being a focus on how can we apply that knowledge to enhance quality of life, functional independence, and safety. So that's what, again, our industry is being held accountable to that, and our physical therapy, occupational, and speech therapists in our buildings. That's what we went to school for, and that's what we should be delivering on as well. So let's see how we can plug everybody in. So let's go to the next. I want to also just hit a little bit on what are the education requirements, in case you don't know, and why would you if you're not a therapist? But physical therapists require a doctorate level in today's world. Assistant, you hear about PT assistants. Assistant level is an associate level degree, and it's required from an accredited program working under the supervision of a PT. And, basically physical therapy assistants can carry out in most states independently the programs that have been established by the physical therapists, but cannot make decisions on, they cannot evaluate, they cannot change the plans, and they cannot determine discharge. And so physical therapy really is an evidence-based healthcare profession. It's focusing on all ages who have problems related, health-related problems that limit their abilities to move. And really our focus is on performing functional activities safely in their daily lives. So we're really focused on mobility, right? And safety and mobility. Occupational therapists require a master's level program for new graduates now. They also have an assistant level, which is an associate level degree required from an accredited program working under the supervision of an OT. The same limitations that I spoke to earlier under PT, but they're very competent in being able to carry out excellent programs to make sure that they are treating injured, ill, and disabled patients through the use of everyday activities, helping patients develop, recover, improve, and maintain the skills needed for daily living. Of course, that's what we're held accountable to, right? Mobility, self-care, and mobility. We've heard that over and over again under PDPM, and the quality measures, everything that we're judged on. And then we have speech language pathologists, which are master's level degree with a fellowship year when they first get out of a school, which requires a year of supervision by a speech language pathologist that's already gone through her fellowship year. And as you may know, speech language pathologists assist with communication, hearing, swallowing, very heavy information and their education program on cognitive skills, how to adapt, how to communicate more effectively. So between PT, OT, and speech, there's a lot of overlap. Speech has a heavy degree and education curriculum filled with neurology and anatomy and neurosciences as well. So we can cross-perform in many ways, which is very helpful in a pandemic when we are short-staffed at times. Under our new PDPM payment model and using the skills of each of the therapists, we're able to plug in holes. We're able to use telehealth. We're able to use all kinds of creative available modes to deliver this care and to really be an integral part of the team to help guide the patient's level of care. So that's what I want to talk about a little bit now. So let's go to the next slide, talk a little bit about how these specialists can help. I also wanted to share, this is a slide that Simple LTC used in a prior quality measure presentation that they had. So when we're looking at the quality measures that we're held accountable to right now, and the VBP, the value-based purchasing program, we're looking at being accountable to, again, functional outcomes. We're looking at long stay indicators. We're looking at successful discharges. And CMS has given us very clear expectations on what we are to deliver on and how we're going to be measured as far as our success. So the functional outcomes are kind of in that lighter, we begin with that, right? That lighter kind of greenish blue. And we're looking at across the post-acute care spectrum, we're looking at the same measures. We're being graded against each other on how have we performed on our discharge, self-care and mobility scoring. You know, how many falls are we having? How many residents have been moving? You know, how many residents whose ability to move independently has worsened in the long stay environment? So how many residents need help with activity of daily living? Is that improving? Is it worsening? You know, these are things that exactly tie into therapy. You know that we've had GG in our midst now for several years, and it just defaulted to therapy in the beginning because those are all things that we work on within our plan of care, within our goals. And here we are again, as an industry, being held accountable to this. So not only short stay, but long stay. And ultimately, are we accurately capturing and reporting on the patient's baseline when we get them versus the discharge status? And are we safely transitioning them home to the next level of care without the return to acute, which is what we're very much being graded on. So how can we help here? How can therapy step in and help and make sure that information, first of all, is accurate and that we're accomplishing our commitment and expectations to our client base and to our communities that we serve. So let's keep going and talk a little bit more about this. Therapy. How does therapy fit into this continuum cycle of this is like the life cycle of rehab, for a better sense of the word. Now, we've put it in a circular pattern, but at any point in time, patients can navigate between all these different levels. But therapy really can be a navigator of this continuum. They can really be a big help here. So on the left circle, we've got those residents that stay with us within the long-term care following a short stay with us, right? So it kicks off with skilled therapy intervention in the very beginning when they admit to us. Let's just take them through that. So we do an assessment. We provide skilled therapy intervention as needed by the disciplines that are needed. Then we move them into perhaps some form of a restorative program, then maintenance, and then perhaps get them re-engaged in their activities without us. Now I can hear everybody saying, well, who has the manpower to do the restorative program at this point? I see it, I hear it. We're doing the best we can to take good care of our patients. But I want to share with you in a minute an example of when therapy actually did provide restorative programs and maintenance programs and move them into safely their activities of daily living, and then watch the patient, watch them throughout their whole stay and make sure they're in the right level of care at the right time. So really being engaged with additional ownership in the responsibility of how much care the patient needs to maintain their highest level of function. Is it a formalized restorative program? Is it more of a maintenance program? Maybe they can come to the gym and do some independent exercises. Maybe they can do them in their room. Maybe their family members can be educated and trained on some maintenance. Put them into a program where we can help walk them to the dining room. There's many different things that we've heard and seen. Therapists are being incredibly creative. We all are at this point in time. So there's that circle of life of therapy within the long-term care after the short stay, from short stay to long-term care, and they stay with us. Let's make sure they're in the right level of care at the right time. Then the second bubble to the right is, how are we managing those patients that come to us and discharge out to the community? So we've got skilled therapy intervention, then perhaps they leave us and go and discharge into the community with home health. And then from there, home health reimbursements changed with PDGM. The lengths of stay in home health are not as long as they used to be. Perhaps when they finish and discharge from home health, they can come back to our outpatient therapy, engage with us again. And then perhaps we can make sure that we're kind of helping make sure that they go back into a re-engagement in the community with activities and, really quality of life. then maybe, we're just keeping in touch with them. We want to make sure that they come back and forth within our setting at the right time without having to go back to the hospital as their first line of defense. So how can therapy plug into our patients, our residents, and make sure that they take a bigger role in owning where they're at in this continuum? How much help do they need? When do they need it? And who's the right level of skill to be able to deliver it to them? And just to make sure we're clear, therapy can deliver, and therapy services that are not skilled can count towards a restorative program. Every state's a little bit different, so we need to make sure that we're clear. The programs are overseen by the nursing program, but therapy can be, therapists, assistants are incredibly talented and skilled at carrying out the program to make sure that we're carrying it out into the real world. So let's keep talking about this continuum and give some examples. We ask ourselves, what can therapy do more to help? What if, and these are just some scenarios that we've seen work. What if rehab coordinated with CNAs on assuming the responsibility for daily bathing, dressing, grooming, eating, and other functional tasks? CNAs are, in many instances, in very short supply. There's a lot of overtime we hear about. There's a lot of agency use that we're hearing about. And when you compare the cost of perhaps an assistant level therapist to what you're having to pay for CNAs, you can utilize and access assistance at sometimes an easier and lower cost situation. So we have seen enormous amount of success in pulling the therapists in. Therapists especially have patients on caseload. Occupational therapists are working on, in their skilled sessions, bathing, dressing, grooming, eating, all kinds of these functional tasks. It needs to carry over to the floor for their repetition and practice, for them to improve and to maintain that and to be able to carry it to the next level of care. So we're talking about practice and repetition, but we're also talking about, perhaps as part of your reimbursable skilled therapy session, doing it in the bathroom, doing it in the bedroom, doing it at the sink for true skilled practice on how to adapt the environment, what do we need to work on strengthening? Where do we need to work on balance? That could be a skilled treatment session, taking the load off your CNAs. And after we are done with that skilled teaching and training, we can practice. Repetition is not the skilled portion of it, but it can count as restorative. And whatever you call it, it's good for the patient to practice. So we can work on formalizing that with you and help take the time from the CNAs that would be spent on those tasks and give it over to therapy. So the CNAs can work with other people that need their care, that therapy eyes and hands don't need to be on. So that can help decrease the burden on your CNAs. What if therapy assumed responsibility of successful restorative programming in collaboration with nursing, as I mentioned before? So what we're talking about here, again, is the non-skilled portion of therapy can be assigned to assistants for repetition and practice in carrying out a formalized restorative program established with nursing, overseen by nursing, but the therapist can deliver that. So again, if you don't have the bandwidth to have a restorative program, you don't have that staff on your nursing team, let the assistant and the therapist in the therapy department that are cost effective do that. And again, we can help with that. And then what if rehab became patient care navigators, right? So again, who is case managing this patient? Social services usually. What if social services is out? What if you no longer have access to social services in your world today? What if you need more help in navigating these patients? We're dealing with patients in ISNPs. We're dealing with patients in bundles. We're ACOs. We need to watch length of stay. When is skill necessary and needing to be continued? When is it time to transition to the next level of care? Who knows that patient's functional status and safety and well-being better than your therapy team if they're really, really engaged and there and present throughout the course of the day and the communication with nursing? We can really help navigate when is it time for discharge to the next level? What do we need to make sure is in place to ensure success? safety and decrease chances of return to acute, therapy should have the answers for you and be able to navigate that with you. It's been incredibly powerful. And then we've got, what if rehab owned the responsibility for portions of the MDS? And we've even seen therapists be trained as MDS coordinators in this shortage. And before, there's all kinds of education and training. Therapists can go and become RAC certified. I did. A lot of therapists do. For whatever reason, we're really drawn to understanding the rules. So MDS it's fascinating. It's an incredibly powerful tool. Therapists should be educated and trained on it. We do it. The REI manual is a fantastic rule book. APACN has provided training for therapists on MDSs. It's available out there. We can absolutely own portions and be responsible for portions of gathering information to help that MDS coordinator, to help the nurses that have, short-staffed and that are just beyond burdened. Let us help with that. We can complete interviews. We can determine prior level settings and the assistance that's going to be needed that was provided before, that's going to be needed after discharge. So why aren't we using therapy to fill these gaps right now? We want to know. So we're going to go to the next slide, which is going to be a poll question, and we're going to see what your thoughts are. So why are facilities not utilizing therapy in this way? These are just a few things that came to mind that we've overcome. Therapy availability or lack of buy-in. Please let us know your thoughts on these. Lack of RAI expertise or knowledge, or perhaps it's just too difficult with communication and scheduling obstacles to use your therapist and your, carry over to your morning ADLs, or you're helping them walk to dine, or, whatever the case may be. Or maybe we just haven't asked. So we would love to see your thoughts. And so I'll turn it over to Ken to share the results.
Okay, thanks, Susan. We'll leave this up for just a few more seconds, give everyone a chance to respond. So just if you haven't yet, please take a look at your screen, respond to our live poll, and then Susan will be able to give us a little bit of feedback real time on those results.
Thank you, Ken.
Okay, thanks everyone for your responses. I'll go ahead and end this, and then we'll share those results. And Susan, I'm sure you have some thoughts on this.
I do. And I put therapy availability and lack of buy-in as number one, because, we have seen that is, that we've, not to speak too much on the personal level, but, we have come in to many situations as a new provider and seen struggles with staffing. We have been able in our situation, and I'll just share, we are, QRM is an in-house rehab management company. But what we've been able to see is that when therapists understand their ability to help and are empowered with the education and the training, the buy-in is fantastic because this is what they want. I'm pretty sure you've probably heard a therapist say something about the fact that it is incredibly frustrating to get a patient to a certain point, discharge them off their caseload, and then they just go back down. Well, our model that we're talking about here, where the therapist is more engaged throughout the course of stay to make sure that they're watching the patient, they're in the right level of care, and perhaps even deliver on restorative and that maintenance, deliver it personally, they get incredibly excited because the outcomes are amazing. And then, therapy availability, assistance in certain markets are a little bit easier. And, with ISNPs and bundles and shortened length of stay, we're finding that there are therapists, and there was a decrease in some staffing with therapy when PDPM started. So there are some therapists available that love this model. They love being able to get involved and impact this. So we've seen it be able to work, and I just think it's really critical that we ask and that we really think outside the box. We'd love to help provide this solution. And then lack of REI expertise and knowledge, clearly you all understand that that's not the biggest obstacle in the room, and there are solutions for that. And communication and scheduling, we can make it happen. And I'm going to share an example of how we can work together. And we have seen when everybody's on the same team, absolutely the communication naturally occurs. It's fantastic. And then some just haven't asked. So I'm hoping that after today, it might spark, if you have a need, it might spark the question. And again, if we can help, we would love to help. We love this model. We've seen the results, and I'm looking forward to sharing with you the results. So I appreciate that feedback. It's kind of what I thought might be your feedback. So let's go ahead and dig into some more of the examples that we've got to share, and some thoughts around how we can specifically get in and help, and why therapy is okay. So we're going to just take, a PDPM stay, for example. The MDS information. I'm going to focus kind of on the PDPM and the MDS for a second. So pre-admission, it's really important from a therapist's perspective to understand where was the patient living before they went to the hospital. Why did they go to the hospital? And most important, why did they not go back to where they were before? That's critical for us. Without that information, we cannot establish a good discharge plan on day one and set our goals. So for us to be able to understand that, we really need to answer those questions that are on the MDS. They're excellent questions pre-admission. It's in section A, where they come from. In GG, what was the prior level of function? And then section Q actually does, guide us to ask the patient what their preferences are, where you want to go, be engaged in what are we assessing and what are we planning and where do they want to go? Where do they want, they need to be a part of this process. So let therapy be responsible for gathering that information and sharing it to all of the interdisciplinary team members to help us all know what does that patient need to be able to successfully discharge. Discharge planning begins upon admission. So let us get involved and make sure that we're allocating the right resources at the right time to help this patient with their individual goals. So that's a pre-admission glimpse into what we can complete and could be responsible for. So let's go to the next one and take it to the next level, which is what happens at admission in those first 3 days. We know GG. We know that the base functional level of independence in self-care and mobility sets the stage. It tells Medicare and the world now in our publicly related information, how much help did that patient need upon admission? And CMS uses that information, and we're talking usual performance, not just what therapy sees here, but usual performance. Medicare uses that along with all the other diagnoses and conditions and information in the MDS to say, this is your expected outcome. Based on what you're telling us you're getting with that patient, here's your expected outcome. So let's get that right. Let's make sure it's not just what therapists see in their eval. Let's make sure it's 24/7 usual performance through all of the caregivers. We can be responsible for gathering that information from the rest of the team. What if we owned that? Not just taking what we say on our eval, but really owning it. And ownership includes collecting and completing the MDS section of GG per the RAI manual guidelines. And if that's not a comfort zone, certainly they can give the information to the MDS coordinators. But when we own this, we understand what are the functional skills needed to improve upon to be able to get them now to that desired discharge level. So let's take it to the next. Now we're past the first 3 days. What can we do to help next? So we have a 7-day window here. We have a lot of information we have to gather. We have to do some critical interviews. We have to make sure that the BIMS and the PHQ-9 interviews are done. And we have seen incredible results with arming the therapist with the education, the training to be able to do successful, appropriate, impactful interviews. And now that we know as a therapist, where is their cognitive impairment level, then the therapist can appropriately set up a plan of care within that cognitive impairment. We know now what their capabilities can be, and we can share that with the rest of the interdisciplinary team so that everybody knows. Susan's she's not all intact. You're not going to be able to expect her to get to this level. She's not going to be able to be independent in a home setting. We got to look at managing our expectations here a little bit. Likewise with depression. If someone is depressed, they're not going to be as engaged in therapy or activities or meals or anything that it takes to help them improve functionally. We have a vested interest in getting this right and knowing what we're dealing with. And oh, by the way, these are very important to your reimbursement, as well as signs and symptoms of swallowing. These are all sections on the MDS that therapy can complete. Section K is the swallowing disorder. So much information gets left behind in the therapist's notes in speech that don't get translated over to the MDS. It's so frustrating to see the money that is there to help cover the cost of care that doesn't get picked up because of a communication gap between nursing and therapy, or the therapist's documentation is in their language. Let us be responsible for assessing and communicating and recognizing changes in conditions so that when your 7-day window is complete, the information is accurate as it can be, and everybody on the team knows what we're working with. So now we've gone from pre-admission to for the first 3 days GG information. Now we've got the all those items on the MDS that therapy can help with for the 7-day window. So next we're going to take it to, now we're live. We got a HIPS code. Well, let's make sure that HIPS code is accurate. Let's all review it. Therapy can put their eyes on it. They can look. We've got all kinds of tools and resources and cheat sheets now. We all know when we're looking at a code, we know what we're looking at for PTOT reimbursement, speech, nursing, and the NTA component. And we know that if a nursing, HIPS code is way down at the bottom and it's reduced physical function, and we know that patient has got a lot of problems. They had IVs in the hospital because, we looked at the hospital, information on pre-admission. Now therapy can be a better partner in coming forward before it's too late to say, hey, we see something here that doesn't look right with the HIPS code. We have got all kinds of analytics that are in use. We've got our own, everybody's got analytics that we're using now to help us identify where we have a missed opportunity. Get your therapist's eyes on it and hold them accountable to it as well. Okay, so let's make sure you get paid right. Let's make sure the HIPS code is correct for your reimbursement on your PDPM. And next, let's go to ongoing case management. So what is it that we want to make sure that we're doing? We want to make sure we're moving towards our goals. We want to make sure that we're getting to those outcomes necessary for the right level of the right timing of transition. Let's make sure they're practicing the functional skills they're learning in therapy. Let's make sure that we use this information to move the patient appropriately through the continuum. And oh, by the way, what happens if something dramatic occurs that would qualify for an IPA? Therapy would probably know it if they're involved in owning it and communicating effectively. Let's hold therapy accountable and responsible and empower them with information to be even more helpful. So let's keep going and look at that a little bit more. Let's go down to the last 3 days of discharge, right? A lot of times people, in the beginning at least, didn't really pay a lot of attention to that discharge GG score, which again, therapy needs to know where that patient is at functionally at discharge. If they're going to go back to the community, we need to make sure that they are at that success. They are set up for success. We need to know where they're going. We need to know, do they need a tub bench? Did they get the tub bench? Has the tub bench been ordered? We need to know the caregiver's been educated and trained on a safe car transfer. We need to know how many steps are in their house. Can they manage those steps? This is back to the basics of good rehab and preparation for a safe transition home. We can do home assessments. We can do that. We can make sure that the GG coding in the last 3 days is an accurate capture of the improvements that the patient's made for your publicly communicated and shared improvements in your building. So let's plug therapy in if we can help you with your MDS, gathering all of this information accurately. So let's go to the next few things that we want to talk about before we get to your questions. I've talked a little bit about this, but what I'm sharing, some of the time that the therapists are going to be spending doing these things that we've talked about truly are part of their skills, part of what's medically necessary, skilled, and reimbursable. So let's make sure that let's just kind of look at this and make sure you're getting paid for everything that is skilled therapy and can help cover that gap. So again, we have to identify prior level of function independence and how much our patients needed before admission to us and before their event that occurred that landed them in the hospital. We need to ask these questions, and we do ask these questions. We put this information on our evaluations. So why are we not gathering this in a way that completes also your MDS? Not only section A, but section GG prior levels and section Q on what the patient wants and where they want to go. So section, what does the patient want for their customary routine and activities? What time of day do they want to bathe? All of these kinds of questions are critical for therapy to know so that we can plug in at the right time of the day so that it's very patient-centered, very driven towards what the patient wants and needs to be able to accomplish their functional tasks at their preference. And then prior home environment, it's critical for us to know that too. This is all part of our skilled assessment and is in very big part of our delivery of care and our discharge planning. So all these different sections on the MDS, again, section GG, prior level function, we are gathering that information. Let us use that time that we are doing that to provide you the information that you need. It is skilled, it is necessary, and it is reimbursable time. And we are establishing then an appropriate baseline so that we can all have expected patient outcomes and goals that are in alignment with what that patient expects. And if therapy is responsible for communicating this to the rest of the team, it can impact the overall success of the program. And then, of course, ongoing assessment of changes in condition, assess our ability to meet our rehab goals, but also could potentially qualify for an IPA, part of our skilled delivery of care and assessment ongoing. So I hope that helps a little bit. I mean, we could spend all day on this, but let's keep going to the next slide. How do you make it happen, right? I've shared that we're seeing it happen. I wanted to, to share what I have learned from one of our buildings that we support, and an exceptional team. And Melinda Rocchetti is the director of rehab and the chief clinical compliance officer. And I was on a call with them the other day with her director of nurses and the person that's responsible for overseeing the CNAs and the bathing, the dressing, the grooming, the scheduling, everything. And like, how did you make this? And I'm going to share with you her testimonial here. And it really did occur quite naturally in the pandemic. When you have a hot hall, you isolate the teams. So they're not moving around between different halls and different patients, right? So naturally, when they were working side by side, what we found were that the therapists and the nurses, they were forced to communicate. We had a job to do together. The patients had to be bathed. They had to be, taken, we need to make sure that they're transferring safely. We need to make sure that they're bathing, dressing, grooming to the highest level possible. So therapy, naturally communicating, therapy just said, hey, I got this. I can do this today. They're on my caseload. This was how it began, just through that collaboration and teamwork. And I want to just share and read this specifically. Additionally, the therapy team shifted their approach to include in-room ADL treatments more than ever before, not only because it was an obvious need, but to help alleviate some of the nursing aid duties during staffing challenges. This has resulted in functional improvements of the residents and in quality measures, a win-win. I love that so much because I had already written my slide deck pretty much when I called to say, okay, tell me, how did you really make this work, right? What really works for you? And everything that she said was like my dream come true. It was fantastic. It's reality. It can happen. It can help. So again, education and training after the collaboration, make sure everybody that's responsible for their task has been educated and empowered and is following all the RAI instructions. And then, it really does just take really good communications between therapy and your nursing team members and your MDS coordinator. We're all on the same team. It's a beautiful thing when we communicate and collaborate, made even more challenging by COVID. So let us help step it up a little bit in therapy to help out. And we're going to show you now some of the results that were recognized. So, again, the quality measures, as we looked at before in that slide that Simple LTC put together, what we're really being held accountable to, some of the critical measures are, did the patient need increased help in their activities of daily living under our watch? Okay, obviously we don't want them to have an increase in the need for help. So the number going down is a good thing. So increased ADL help at Villages of Lake Highland. These are all came from Melinda. Let's look at the difference in, from 2020, January 1, 2020, 27.3% of the patients had an increased need for ADL help. Then it went down a little bit at the end of the year. Then it went back up again with one of our COVID tsunamis to about 25%, but still better. But when the team came together in this last, the end of 2021, look at what happened. Now that dropped down to 16.4% of their population needed help, increased help with their ADLs. That's a beautiful thing. That's a testimonial to collaboration. And, the other thing are accountable to is making sure that their ability to move independently does not worsen. If it worsens and if that number goes up, that's a bad thing. We're not doing our job as well as we should be, right? So back in 2020, we had some spikes. It was 37.4% had the ability to move independently worsened. But when we look at the end of 2021, where we pulled together, that improved dramatically down to 18.6%. And then how many of our patients are making improvement in function? Back in 2020 of 63%, now 71% of our patients are making improvement in function despite COVID and isolation and all of the side effects and long-term effects of COVID. So collaboration, this just was such an incredible visual straight out of their Casper report that we graphed. So the linear graph just tells the story beautifully. You want more independence in functionality, which is what you see in that top line, and you want their ability to move, you want to see that the worsening is going down, which is this beautiful visual here. So I hope that you can see this as positive as I'm excited about. So let's keep going. Just real quick here. We'll go to, again, what are the results? We're looking for person-centered delivery of care. And by this approach, the patient is number one, they're involved, they're engaged. We're basing all of our decisions and our interventions on the patient's scenario. And if therapy skills that we're working on in the department and in the little time that we have with the patients, if we can carry that over to the floor for repetition and practice in their everyday life, then a couple of things. We're gonna have improved accuracy in the MDS data because we're all responsible for it and we're living it with the patient. And most important, we're going to have successful outcomes and transitions and patient satisfaction. So one of the side effects that is not measurable yet, but was one of the testimonials that Melinda and her nursing team gave me was the nurse's satisfaction, the therapist satisfaction, and the family satisfaction, not to mention the patients love the ability to practice and improve and have the whole team pull together to help them. So I'm kind of wrapping up here. So let's go to the next slide. We've given you the resources here to obviously the MDS and REI manual, the news feed articles that I quoted. And then if we keep going on, we're going to get to a little bit about QRM. Just, again, we're an all-inclusive in-house rehab management program company. That's all we do is help our clients who are in-house, identify how we can be as successful as possible. Those outcomes mean the world to all of us. And we get there through recruitment and operational management and programming and clinical reimbursement support and education and training and ADR guidance and data analytics, because that's where that's our story that we have to tell. So we're in over 30 states now in over 470 something locations. Our whole focus is on the success of our clients and our operators. So a little bit about us. We can move forward. This is some contact information for us. And then Ken, do you have something next that you want to share a little bit?
Yeah, just real quick, just a quick note on Simple LTC and Simple Analyzer before you move on. Of course, Susan's covered a lot of critical information about data analytics. So this is what Simple does. So Simple Analyzer is our key product currently used by several thousand facilities around the country, provides real-time, predictive, proactive MDS analytics, real-time quality measurements, allows you to do pre-transmission scrubbing before the data goes to CMS, so you see it before they do. Built-in PDPM performance tools and 5-star insights for all your QMs, including critical rehab and discharge statistics, helps you manage your clinical data in real time, so you can take a proactive approach to data, which is, as we know, more critical than ever these days. So that's our quick note on Simple. So Susan, are you ready to move into Q&A right now?
Sure.
Okay, I'm going to go ahead and turn it over to Amy Gerlach. Amy's been monitoring the questions. So Amy, what's our first question?
Thanks, Ken. So we received quite a bit of feedback and statements that I think are good talking points, and then one question. So the first statement was that there's a big difference between therapy availability and buy-in. We've been experiencing great difficulty in filling our open therapy positions, which you did cover.
Okay.
The next note was that This individual asked how come therapy cannot be MDS coordinators when all the assessments are almost therapy related. They said that nursing must be involved as well.
I would always refer back to your state's guidance, but according to the RAI manual, and the education and training, it's critical that whoever is completing the MDS be trained. And there are RAC certification programs available through APACN and other organizations, many other organizations, for therapists to become MDS coordinators. Now, your organization might have a certain position on that. Totally respect that, whatever the case may be, but they are able to become MDS RAC coordinators, MDS certified RAC coordinators.
Thank you, Susan. And finally, we don't have a social worker on the team, and it doesn't appear that anybody is picking up case management. I would like to do this, but I know I need to learn more. Any suggestions on formal training?
We would love to help tackle that. So, ask if you haven't asked, definitely ask your rehab provider. And, let's get some education and training on those sections that the social worker was responsible for. And then, empower your point person that you assign, whether it be your director of therapy or a therapist on the team that has skills in patient care navigation. Let's empower them. They need to understand your reimbursement. They need to understand your authorization processes. Who do you have contracts with? Who is your managed care provider? A lot of therapists are already responsible for obtaining authorizations and defending the requests for additional therapy intervention and lengths of stay. And so I think that, it's absolutely doable to help fill that much of that void between the therapists and some of the other team members. It's critical that that the entire team weigh in on when it's the right time to transition, but also to have a point person be that care navigator that fights the fight on behalf of the patient's needs. So we would love to help dig in there and help educate and train. And there's a lot of people that would help with that. So definitely don't be afraid to ask. I think that's going to be my main message here, is that for those of you that see a need and perhaps this could be a solution, please don't be afraid to ask. You can ask us anything at any time, even if you're not our client, anybody can ask us a question at any time. And we would love to help guide and support you and provide those resources to you as well. So Amy, did you have any other questions?
Yes, actually, we had a couple more trickle in. So if you don't mind, we can't find therapists to use. So we use a lot of contract therapists, and I'm afraid that my costs will increase. How does your company justify an employee doing this?
I appreciate that question. So again, we support over 470 something skilled nursing facilities. And I think we have less than 5 contractors in any of those buildings. Our recruiters are incredibly talented, and it has just been a blessing that we've been able to get the right staff to meet the needs of the patient, and also to be able to utilize telehealth has been a godsend. Honestly, that has been fantastic. And to use it appropriately is critical, to make sure that the team members understand the rules, the regs that surround it, to be able to use it appropriately, to be able to use your therapist, across the disciplines based on the needs of the patient, based on the skills of your therapist. We need to just make sure that we're using the right therapist at the right time. And if you're short on a physical therapist, occupational therapists can absolutely step in and handle those needs of the patient, and vice versa in many situations. So I would say challenge your rehab provider to help with solutions. And, we're all out here to help. So it's not easy, but it can be done. And we appreciate the cost situation, which is why I spent so much time on a lot of the information that we gather for the MDS, and being used in a little bit different way can actually be reimbursable time. And in some instances can be less costly than CNA, agency, and overtime. So we help all the time with cost analysis on that, making good decisions. I hope that helped.
Wonderful. We actually have someone who says that they've started doing this at their facility, and they actually find that the therapist and the CNA retention has gone up 75%. Are you also seeing this?
Again, that was, the satisfaction is huge. Therapists are in this to make a difference. They are. And when they can really see what happens when nursing, the CNAs can work together with therapy to see the carryover for their patients through the day in and day out timing. It's fantastic. It really does lead to satisfaction, and you're not working, then the CNAs don't feel like they're just on their own, right? Nursing is not on their own. They have had to burden, the children, incredible burden through this. Anything that we can do to help, for sure, is going to help. Win-win-win, as Melinda put it.
And actually, that's perfect for the last question. An inquiry just came through asking if QRM works with the Melinda example that you provided.
Yes, we do. Yes, we have for quite some time, and we're very honored to be able to have that relationship with Villages of Lake Highlands. So we're thrilled at how it's worked out and the outcomes for the patients and the therapists and the nurses. So love this. So keep it coming after the fact. You know how to reach us. We're in this for your success. So thank you for your time and your participation and your questions. And Ken, thank you again for the opportunity to partner with SIMPA LTC.
And thank you so much, Susan, and also for your help, Amy. I want to thank Susan for sharing her expertise. Always a pleasure to work with QRM in getting some of this critical information out to our industry and our client base. Thanks again, Susan and Amy. And so as you see on the screen now, we will be posting a recording and handouts and some additional resources on our website, simpaltc.com/staffing-shortages will be that URL. Give us a little bit of time to get the video finalized and post the handouts, but those will be up a little bit later today. And so again, thanks to Susan and Amy, and thanks to everyone for joining us today. We hope you found it helpful, and we hope everyone has a great day.
Thank you again. Stay warm.